A very good afternoon to all. Don't wait, the time will never be just right. This was well said by Napoleon Hill. And that was well executed by William J. Kellen, Greg L. Semenza, and Peter J. Ratcliffe for the Nobel Prize in Medicine or Physiology in the year 2019 was awarded to them for their extraordinary work on oxygen sensing and adaptability. Is it a real breakthrough in medicine? A Nobel for the discovery of cells sensing oxygen. The pioneers in this research were William J. Kellen, Greg L. Semenza, and Peter J. Ratcliffe. William Kellen works at the Dana-Farber Cancer Institute in Boston, Massachusetts, whereas the physician-scientist Peter J. Ratcliffe works at the University of Oxford, UK, and Francis Crick Institute in London. Geneticist Greg L. Semenza works at the Johns Hopkins University in Baltimore, Maryland. Oxygen. Who knows it better in this COVID-19 era? The importance of this entity. Yes, it is so important. Let's go into it. Oxygen has been since ages associated with ischemic heart disease. Yes, the hypoxia, Alzheimer's disease, COPD. Yes, indeed. COPD, stroke, diabetes, and above all, cancer. Yes, cancer. Let's go into it further. Oxygen sensing in oncopathology. Yes, when you're talking about cancer, it's oncopathology. Hypoxia and cancer have been intrinsically related to each other. Hypoxia results in genomic instability, resistance to apoptosis, autophagy, tumor angiogenesis, induction of cancer stem cell phenotype, epithelial mesenchymal transition, and metastasis. Let's see, how does it happen? Yeah. Who is this master regulator of oxygen homeostasis? It is none other than the HIF. Yes, indeed, it is none other than the HIF. HIF, or the hypoxia inducible factor, was discovered by Greg L. Semenza. It has basically two subunits. Yes, you're right, it has two subunits, the alpha and the beta. The alpha and the beta. What about this? The beta subunit is constitutively expressed, whereas the alpha subunit is inducible. This beta subunit is also referred to as the aryl receptor nuclear translocator. Let's go into it further. HIF1 alpha and 2 alpha are different entities. Let's see. While HIF1 alpha is ubiquitously expressed, HIF2 alpha is detected in the endothelial cells, kidney, fibroblasts, and hepatocytes. The oxygen sensing pathway says it all. Under normoxic conditions, the HIF1 alpha undergoes a prolyl hydroxylation in the presence of prolyl hydroxylase enzyme, couples with VHL protein, the von Hippel-Lindau protein. This protein further on degrades this HIF1 alpha, which undergoes a proteasomal degradation. Whereas under hypoxic conditions, what happens is that the HIF1 alpha intrinsically moves inside the nucleus and couples with the aryl receptor nuclear translocator, or better off, the beta subunit. And this is the credit of William J. Kellen, Greg L. Semenza, and Peter J. Ratcliffe. They decoded the pathway. So the pathogenesis of tumorigenesis and metastasis is now decoded. Hypoxia results in decreased VHL. So what happens if VHL decreases? If VHL decreases, there is no proteasomal degradation of this HIF1 alpha. Hence, this HIF1 alpha moves inside the nucleus and undergoes coupling with the beta subunit. So what happens then? If the VHL decreases, there is an increase in HIF1 alpha, which further on binds to the EPO gene. This is the erythropoietin gene, or there are similar genes like the VEGF, carbonic anhydrase 9, etc. These are nothing but the targets of HIF1 alpha, which subsequently activates the PI3K AKT-mTOR pathway, RAS-RAF-MAPK kinase pathway, increases VEGF tumorigenesis, and further on also increases the snail and twist proteins, which are implicated in metastasis and epithelial mesenchymal transition. Wow! Isn't the pathway decoded? Let's see what happens then. The hallmark of cancer cells, as is known to us, is angiogenesis. But how does this happen? When the VHL decreases, HIF1 alpha increases. So what happens is that, let's show that. So this is point number 1. Here you go. This is the one that I've targeted. Okay, so you have the HIF here, and under low oxygen conditions or hypoxic conditions, rather, there is no degradation of this HIF. It moves inside the nucleus and increases by binding to the beta subunit or the aryl receptor nuclear translocator. So further on, what happens is that there is increase in this VEGF. Why does the VEGF increase? There is an important thing that you need to know, that the HIF has certain target proteins. Okay, and these target genes, one of them is EPO, the other is VEGF, carbonic anhydrase 9, and several others. So what happens further is that when the HIF is nuclearly translocated, there is an increase in this VEGF, which further on binds to the VEGF receptor. And as we all know, what is this VEGF? It is nothing but the vascular endothelial growth factor. Yes, you heard it right. Vascular endothelial growth factor. So what happens is that there is increase in these vessels, but there's a problem. You know what? Let's see. These vessels are rather collapsed, narrowed, and have very narrow lumens. Look at this. Okay, so this is one of the healthy tissues, and if this is a healthy vessel for that matter, whereas this one here, okay, let me show this again. This one here. Yeah, here. Okay, so this one is a bad vessel. Okay, it's a neoangiogenic vessel. Okay, the lumen is somewhat collapsed and they're narrowed, and there is low perfusion. So what happens is that these low perfusion vessels in a tumor results in hypoxia. So when I'm talking about point number 1 here, okay, why does hypoxia happen in the first place in a cancer cell? The reason behind that is the narrowing of these vessels, and that subsequently results in increased VEGF and further on neoangiogenesis. But there are some pseudos. You know what? There are some pseudos. What are these? Pseudo-hypoxia. You have inhibition of electron transfer in succinate dehydrogenase complex due to mutation of the SDHB, that is succinate dehydrogenase B or D genes, which causes an increased succinate. Okay, so increased succinate and inhibition of prolyl hydroxylase. So let's just sum it up here. I'll just sum it up here for you. Okay. So increase, increase in the succinate. Okay, so increased succinate causes decreased prolyl hydroxylase. Okay, so what happens if you have increased succinate? Okay, there is decreased prolyl hydroxylates. Can we just go back to the pathway that was discussed by our pioneers? Yes, they've decoded it right. So increase in the succinate results in decrease in the prolyl hydroxylase. A decrease in the prolyl hydroxylation causes this HIF to shift inside the nucleus. Wow. So yes, you've got it right. Increased succinate causes a decrease in prolyl hydroxylase, which causes HIF1 alpha to move inside the nucleus and result in tumorigenesis via neoangiogenesis. Wow! Even VHL mutations result in decrease in VHL and decreased HIF1 alpha degradation moving inside the nucleus. It causes tumorigenesis. So these pseudos can also result in hypoxia. Let's sum it up further. The SDH gene mutations have been detected in paragangliomas, pheochromocytomas, GIST, you know what? It's the gastrointestinal stromal tumor, as you know, RCC, renal cell carcinomas, pituitary adenomas, pancreatic neuroendocrine tumors. Whereas the VHL gene mutations have been noted in retinal hemangiomas, CNS hemangioblastomas, endolymphatic sac tumors, lung cyst, pheochromocytomas, pancreatic tumors, kidney tumors, epididymal tumors, broad ligament, and several others. And you must know that if you have this biallelic inactivation of this VHL, then that results in accumulation of HIF. Remember the pathway that we talked about. So as I discussed, yes, there are several targets, one of which is VEGF, the other is carbonic anhydrase 9, EPO, erythropoietin gene, GLUT1, and several glycolipid enzymes. But what's the importance? The importance lies in the new drugs. Yes, you got to hit the hammer on the nail. It is the HIF prolyl hydroxylase inhibitors that are here: roxadust, vadadust, daprodust, molidust. Okay, and in addition, you have the NSC 134754, which is under phase 3 clinical trial. It decreases both HIF2 alpha as well as HIF1 alpha. From the pathologic diagnosis point of view, we have HIF1 alpha monoclonal antibodies, which can detect the presence of high levels of HIF1 alpha. The normal localization is in the cytoplasm and nucleus. Okay, the cytoplasmic localization is seen under normoxic conditions, yes, and the nuclear translocation under the hypoxic conditions. Besides that, we have the SDHB immunohistochemistry. We also have carbonic anhydrase 9, VEGF, and VHL. So concluding, hypoxia has been implicated in the pathogenesis of several disease states. The master regulator of oxygen homeostasis is none other than the hero of the show, the HIF. Yes, the oxygen sensing and adaptability via HIF has serious implications on oncopathogenesis. Anti-HIF targeted therapy are under phase 3 clinical trials for several tumors. Anti-HIF monoclonal antibodies are being actively used by researchers like us in the field of pathology for the diagnosis of tumor hypoxia. It is a remarkable breakthrough in the field of medicine, and the credit goes to none other than the 3 great scientists. Earlier, we had been using anti-VEGF agents like bevacizumab as a modality for targeted therapy for several tumors. But now, with the advent of anti-HIF targeted therapy, tumorigenesis can be stopped at a much earlier step. Eventually, this is a decade of hypoxia. It's a new era in pathology. The root cause is none other than hypoxia. SDH mutations, VHL mutations, increased VEGF, increased HIF, but all of it, the star of the show remains HIF. Yes, it is none other than the hypoxia inducible factor. So thank you so much to William J. Kellen, Peter J. Ratcliffe, and Greg L. Semza for giving us this great gift of decoding the oxygen sensing and adaptability. Thank you so much for listening.